This is a presentation on staffing and scheduling by Jesslyn Knoll. Here's an image with some key terms that we'll be using during this presentation. Demand management, patient classification system, nursing care hours, full-time equivalent, staffing mix, and block scheduling. Staffing. The goal of staffing is to provide appropriately skilled and amount of staff, referred to as nursing care hours, for the predicted patient care needs, or patient care hours. This is determined by studying workload patterns. Managers must take into consideration days of the week or times of the year that have higher census or patient care hours. And there are guidelines from the Joint Commission, but they just state that the organization must set and meet whatever criteria they develop for staffing. There are no specific numbers or guidelines given. There are also recommendations from the American Nurses Association, and the ANA recommends that organizations focus on nursing skills and competencies to provide quality nursing care, which is a shift from industrial, technical model of providing staffing. Two types of staffing methods that we're going to talk about: patient classification systems, or PCS. This is also referred to as a patient acuity system. This method allows the patient's needs or acuity to dictate the staffing ratio. It's assessed at midpoint in the shift to determine needs for the next shift. It is difficult to use, however, due to last-minute changes in staffing or patient condition, such as a nurse calls in sick or a patient receives a new diagnosis that the oncoming nurse is unfamiliar with or incompetent to care for that patient. Demand management is another type of staffing method, and this uses evidence-based practice to look at trends in demands for nurses to develop set protocols that provide positive patient outcomes. This allows the manager to staff for days at a time rather than just shift to shift. Nursing care hours is a daily calculation of workload trends for a specific patient diagnosis. This may vary based on the type of patient or the level of care that they need. For example, a patient in critical care requires a greater number of nursing care hours. Nursing hours per patient per day are calculated by dividing the number of nursing care hours by the total census of a nursing unit. Determining full-time equivalents. One FTE is 40 hours of nursing care per week. This can be met by a single employee or several part-time employees. The job of the manager is to calculate the number of FTEs needed to staff the unit 24 hours a day, 7 days a week. Several different formulas can be used to calculate how many FTEs are needed. And staffing mix refers to the number of staff needed in addition to RNs, including licensed practical nurses or unlicensed assistive personnel. We must consider the patient needs based on the patient classification system, and units that require frequent patient assessments, education, and discharge planning will require more RN FTE, since these tasks are not in the scope of practice for LPNs or UAPs. Block staffing. This is useful in units like labor and delivery and the emergency department, where it's more difficult to assess trends in patient care needs. A set staff mix is scheduled for every shift, but during peak hours, additional staff may be scheduled. So say the emergency room is particularly full between 6 and 10 p.m., they can schedule additional RNs, UAPs, or unit secretaries if needed during that time. And then scheduling. Two ways to do scheduling would be self-staffing. This permits the unit staff to dictate when additional nurses are needed, or if a nurse can be sent home based on the workload of the unit. This is really empowering to bedside staff. And then self-scheduling is another method. This is where staff can create and manage their own schedule, but does require oversight from the manager to make sure the unit needs are still met. This is a video clip on staffing mix. I could not embed the clip so that it would play during the presentation, but I would encourage you to follow this link out to the web. It is just about 2 minutes long, and it talks about the importance of staffing mix in relation to budgeting and providing quality care. It also touches on practicing at the top of your license, whether you're a nurse practitioner, an RN, or a UAP. So in this map of the United States, the orange states have enacted some kind of law on nursing staffing. California definitely has the most strict laws. They have a staff minimum for different levels of care, and that minimum must be met 24 hours a day. Other states have less strict regulations. So what else does the literature say about staffing and scheduling? Allow technology to help. Kathy Douglas states that technology is not being utilized enough to incorporate evidence-based practice for staffing and scheduling. As healthcare advances using EBP, so should staffing and scheduling. There have been programs developed that can assist in this, but she really emphasizes that nurse managers must own this transition to using technology for staffing and scheduling. The benefits include that we can improve efficiency and effectiveness. This would empower staff with scheduling options and also promote fairness. It would improve communication between units and departments, and it would systematize collecting staffing data. I also found literature on the effects of staffing on quality. In 1 year in the country of England, 30,000 patient safety incidents were attributed to inadequate staffing. High nurse-to-patient ratios led to staff burnout and declining quality of care. Lowering ratios is not the only answer to improving quality of care, however. Staff should be well managed and applied in areas that they are most passionate about. There is currently inadequate data on the appropriate number of staff to provide quality care to all levels of care. Staffing data, patient outcomes, and quality indicators need to be carefully assessed for continued improvement. And then lastly, I read an interview with Carol Ann Kavoris. She has been a nurse executive for many years and just had a variety of recommendations for improving staffing and scheduling. She really emphasized the need for nurse managers to sit on senior leadership boards with other physicians and hospital leadership. She encouraged senior leaders also to adopt a unit where they would spend time each week. And the purpose of this time would be to understand the experience of staff and patients through observing staff working and rounding on patients. She recognized that as the length of patient stay decreases, more nurses are actually going to be required. And this is because education and discharge planning need to happen more quickly. This is important to consider since the typical length of stay for patients is decreasing as healthcare changes. She also talked about preparing nursing students with coping strategies. Often new nurses feel that they can't keep up with the fast-paced healthcare environment, but we need to support them and encourage them, acknowledge their feelings, and help them cope. Lastly, she recommended a shift from staffing ratios to acuity systems. This would involve using the electronic health record to assess acuity and matching to nurse with the appropriate competencies. Here is a list of my references used. Thank you for watching.